Hello everyone, this is another ASMR and Learn, and today we have a special request to go and talk about vertigo. I struggle with this personally, so I'm happy to talk about it, but I do have one of my medical school textbook type programs pulled up so I can read just a little bit about vertigo. So let's learn or relax. Or both. Let's do it. A side note, Padme is here listening. She has just decided to steal my jacket. Okay, so what is vertigo? Vertigo is the false sensation of motion, such as spinning or swaying, caused by dysfunction of the inner ear, which is peripheral vertigo, or the central vestibular system, which is central vertigo. It is often confused with similar terms related to dizziness, such as disequilibrium or lightheadedness. Peripheral causes, such as benign paroxysmal positional vertigo or vestibular neuritis, are typically benign, while central causes, such as posterior stroke, tumors of the posterior fossa, can be life-threatening. Clinical features and neurological examination findings can help identify the underlying cause. Depending on the clinical presentation, targeted examination maneuvers may also be indicated. In patients with episodic triggered vertigo, Ladix-Hallpike maneuver can be used to confirm benign paroxysmal positional vertigo. While in patients with acute vertigo without a clear trigger, head impulse nystagmus test of skew examination can be used to assess for central causes. Urgent neuroimaging is indicated in patients with suspected central vertigo. Further testing, including laboratory studies, is not routinely required. Treatment depends on the underlying cause. Okay, so since vertigo and dizziness get confused, let's compare the definitions. So vertigo, as we said, is a sensation of spinning or swaying of oneself or of one's surroundings while stationary. So dizziness, on the other hand, is a disturbance in the spatial orientation, but there's no false sensation of motion. So you might feel off, but there's no spinning or swaying of you or the room around you. Also, don't want to get confused with vertigo and presyncope, which is the feeling when you're about to faint, which is usually lightheadedness or near loss of consciousness. Now, there are many medical conditions that can cause vertigo. As we already discussed, there's central vertigo, which has to do with things with the cerebellum, which is a part of your brain, brainstem, vestibular nuclei, another part of your central nervous system, or just dysfunction of the central nervous system in itself. And then peripheral vertigo has more to do with the inner ear. Sometimes vertigo can be an emergency that needs immediate management, such as a stroke or acute obstructive hydrocephalus, which can be caused from a posterior fossa tumor. Those are things that need to be addressed immediately, which those would count as central vertigo. Since vertigo is associated with neurological features, there are other symptoms that tend to be associated with it. These can help determine if it is central or peripheral, but since there is a lot of overlap, it is hard to narrow down. So let's go through some of the differences between them. If the cranial nerves are affected, that usually would suggest central vertigo, which would be a severe ataxia, presence of dysmetria, dysphagia, dysarthria, or diplopia. Basically, anything have to do with cranial nerves, so eyes, talking, stuff like that. Peripheral vertigo can have a mild gait disturbance, which is how you walk, and there could be nystagmus, hearing loss, or tinnitus, which is like ringing in your ears in peripheral vertigo. So nystagmus, which is involuntary eye movements, there's different kinds. So if it is going one direction, usually horizontal, that would suggest peripheral. In central vertigo, horizontal, torsional, or vertical would be seen more often. The sense of motion of the swaying or spinning is usually more severe in peripheral vertigo and mild in central vertigo. Nausea and vomiting is also seen more commonly in peripheral versus central vertigo. It varies. Now, there are vestibular syndromes that are used to classify based off the onset, the trigger, the timeline when you have vertigo, because your vestibular system has to do with your balance and your orientation. So if that's not going well, you're going to feel that vertigo and just things aren't going to be feeling right. There is acute vestibular syndrome, which means a short duration, which is acute onset of continuous vertigo, gait instability, nystagmus, and nausea with or without hearing loss that can be worsened but not triggered by movement. It usually lasts days to weeks. Episodic vestibular syndrome is recurrent episodes of vertigo, often associated with gait instability and nausea that typically last seconds to hours, may be triggered or spontaneous. And then chronic vestibular syndrome, which is the presence of continuous vestibular symptoms for weeks to years. For the evaluation of vertigo, there has to be a focus history. Specifically, you want to know the onset, triggers, duration, if there's anything that makes it better, anything that makes it worse. Basically, you want to narrow down, is it peripheral or central as well as you can, because again, some of those can be emergencies. So you want to look for risk factors for ischemic stroke and anything similar to that. For the physical exam, we would want to rule out any sort of orthostatic conditions. So orthostatic hypotension, which means your blood pressure drops when you stand, or orthostatic tachycardia, which POTS is an example of that, where your heart rate dramatically spikes when you stand up. You also would do a neurological exam with the full cranial nerve examination and examine the cerebellar features, which has to do with your movement and balance. Evaluate for nystagmus, because again, that can help identify central versus peripheral and gait. And look to see if there's any focal neurological deficits that you would see like in a stroke. Then there are more specific maneuvers that can be used, such as the Dix-Hallpike maneuver, which has to do with moving the head in a certain way to try to provoke the BPPV, so that can count as a diagnostic test, and other things like the HINTS examination to screen for central causes. If there is any reason to suspect central vertigo or chronic vertigo, neuroimaging is recommended to try to find the cause, and this is usually an MRI. Depending on the history, physical exam, and everything else, there are certain tests that can go further, like lab tests for vitamin B12, toxicology, EKGs to rule out cardiogenic causes, audiogram for hearing loss, caloric testing, which tests for nystagmus. Management for peripheral vertigo can be vestibular therapy. There's also vestibular suppressants, first generation antihistamines, benzodiazepines. Management of central vertigo is to treat the underlying cause. I will say, as someone that deals with vertigo, my neurologist has me take Dramamine, which is a motion sickness medication, and that seems to help. But that completes the lesson on vertigo. I hope you enjoyed it. I hope you even learned something. Thank you for listening, and I will see you later.